the session.
Hello, everybody. Warm welcome to the last Catalyst seminar of the year, where we will be hearing from Dr. Tom Osborn and also Dr. Joshua Buckman about student mental health. So the seminar title is Mental Health at the University, what is specific about mental health experience of students and how they navigate complex web of services available to them. It's a very timely topic. Student mental health is regularly in the news at the moment, and it's perhaps not always quite as evidence-based or systematically done as we might hope for. And this is something where we at UCL can really lead the way in making a difference. And I will briefly tell you about the two speakers that we have. Dr. Thomas Osborn is a research fellow in the Clinical Education and Health Psychology Research Department and also with NIHR ARC North Thames. He completed his PhD in 2023 and his PhD looked at access to mental health care for higher education students. He's currently involved in a number of applied health research projects on the topics of well-being and mental health in higher education. And has interest in looking at the interaction between settings such as universities, health services, access to healthcare, and implementation research. I'll introduce our second speaker before his talk. He's going to arrive to this session a little bit later because he has to chair a teaching meeting, but he will be here I'm told by 15:15, so well in time to give his own talk. So I'm going to now hand you over to Tom.
Thank you very much, Essi, and thank you very much for the opportunity to speak today. It's really nice to see so many people. I will just go ahead and share my... So hopefully everyone can see that. We divided, so Josh and I will basically be conducting one talk, but divided into two parts. I will talk a little bit about the context of youth and student mental health, and also the service context in which students access care and also staff are professionals are working in. Giving essentially London as a case study throughout. And then in the second part, Josh will talk about a worked example of perhaps how we could provide a more integrated approach in the NHS and how it could interface a bit better with universities thinking about mental health and substance misuse disorders. So, available evidence, or certainly the most recent National Prevalence Survey, indicates that common mental disorders have increased markedly in the last 10 years, particularly among 17 to 19-year-olds, of which university students make up a reasonable proportion of. So roughly a third of 18-year-olds are enrolling in a university course. And also this potentially indicates a high level of need for mental health support, both in the general population. And in students, there does seem to be, yes, they have increased, they do seem to have increased as well. And it doesn't seem to be over and above what they have, the increases in other groups of young people. So these are data from by Evie Tabor and colleagues looking at caseness, so the possible presence of prevalence of common mental disorders, and also the average or the mean score for using a validated measure of mental health symptoms. And it just shows sort of an increase since 2015 in students and non-students. So what broadly characterises the UK student population? Well, they tend to be a majority female, and this is important because the prevalence of common mental disorders, PTSD and self-harm tends to be higher in the general population among women. Both domestic and international students move away from existing support networks to study, and they tend to be a majority young adult population, which is obviously a key developmental period, both in terms of forming identity, developing an education, career, and also independence as an adult. And young adulthood is, as I'm sure many would know, is a broadly high risk period for the onset of a range of mental disorders. And various researchers have argued that the university environment might contribute to risk and potentially resilience as well. For example, the formation or juggling new relationships, separation from families, finance. So as I'm sure many of us know, universities are not necessarily cheap. And particularly in London, there may be additional costs such as housing and the need to balance work and study. There may also be particularly more academic pressure, and also students may be more likely to drink and take other substances, which might increase the risk of mental health problems. So essentially what we're seeing is a sort of a context in which prevalence is going up in young people in general, and also many students attend during a high risk period. But what is the service context in which they might be gaining help? So this is data from NHS. These are data from NHS England, and broadly they show a really quite substantial increase in first contacts with mental health services in the previous 12 months. And this does not display increases since 2020, where the number of first contacts in the previous 12 months was nearer 500,000. And this is important because it illustrates a context in which there's significant demand for mental health services in the general population, and this might have impacts on universities, because where students may be unable to receive care in the NHS, they may then seek help via their university, which could place quite significant pressure on existing university services. What is demand for university-based services and students? Well, we don't really know. We don't have good data for service demand, primarily at a national level, primarily because there are challenges identifying students in NHS data, and university services do not connect a standard set of indicators nationally. However, reported disability to university and college admission service can sort of serve as a bit of a proxy, because universities have a statutory responsibility to help students who report a disability. And we've seen mental health we've seen steady rise in reported disabilities, and as a proportion of that, mental health has become increased nearly fivefold. This is potentially positive. So perhaps it indicates that there's less stigma, students might be getting the help that they need. But also it has material implications for universities, as I mentioned, because they have a statutory responsibility to help to provide services. And perhaps it indicates that there might be greater demand for them. And this is in the context of increased demand for the NHS. Available cross-sectional evidence suggests that actually very few students receive necessary support. So potentially there's quite a large amount of unmet need within the student population. And available qualitative studies predominantly were conducted before 2010 describe challenges students describe challenges related to identifying what normal distress and stress is, a lack of knowledge of available services, potentially a stigma associated with not coping at university, and also other students might have a preference for self-reliance. for suggesting potential reasons why students might not seek help and or might find finding the right help challenging once they do seek help. So where might they go? Well, this is sort of a simple representation of the broad types of services within the NHS and universities that students might go to. There are obviously a range of third sector services, so for example, Mind, but these potentially could vary based on need and by locality quite substantially. But broadly, university student services were set up to provide advice and support and adjustments to for study, and also provision of counselling in the short term. And broadly, they have, as anyone else within the general population, would have access to general practice and NHS talking therapies, and in emergencies, and emergency department and crisis services. So in students, so existing qualitative research was conducted before 2010, and not in the current context in which students might be so of increased demand. So sort of how do students experience the current system? So fellow colleagues, conducted some 16 interviews with 16 students accessing mental health services in London. And broadly, students described accounts of help-seeking experiences characterised by challenges identifying where and when and for what problems to seek support, particularly concerns related to stigma and confidentiality, whether a problem is too severe or not severe enough to warrant support, as well as significant efforts and know-how to get the right support, so which potentially advantage, perhaps paradoxically, those who'd had previous knowledge of accessing support. There was also a perception that support was insufficient, limited in choice, and needing to access multiple services to reach the right input. And overall, it reflected a broader picture of perhaps fragmentation and potential for disengagement once a decision to seek help had been made. So what's it like for staff working across a range of different of these key services that I identified a couple of slides ago? So we conducted a qualitative study of staff working in university counselling and advice services, general practice, talking therapy and crisis services in London in 2023. Exploring broadly how they understood the mental health problems that students presented to them, how they helped them, and what sort of helped them, what helped them do that in their current work setting. And overall, staff working in both universities and the NHS described accounts of increasing demand for their services from students, more complex and severe presentations, some students having potentially quite high expectations about what could be done in the context of current demands on the system, and a fragmented landscape of support. So, for example, GPs and NHS staff had limited knowledge of university services. Staff in both sectors described limited formal and informal communication and referral pathways. And this was perceived to be driven partly by an increasingly selective NHS mental health services. So, for example, autism and ADHD services are a characteristic example where waits can be over 2 years. An expectation that universities needed to manage risk among students, so to do something, particularly when a student was presenting as high risk, and overall large increases for demand for NHS services. And this together was perceived to have implications for university-based services and NHS general practice in particular, who were interacting with students with more severe and complex presentations, as well as staff in emergency and crisis services who also saw sporadic presentations to their services from students in crisis. So what can we conclude? Firstly, that there's an increase in demand for NHS and university-based mental health services, potentially increasingly selective acceptance thresholds for specialist care, a landscape perhaps perceived, at least in London, as fragmented by both students and professionals. And the implications of this are that potentially some students are seeking help very early, whilst others are only doing so in crisis. It's not clear who those students are necessarily. Currently, there's potentially quite significant effort and sort of practical knowledge to get the appropriate support, and that potentially increases the risk of disengagement from students. And for staff, they're assessing and helping more severe and complex presentations potentially, and that leaves open the potential for service interventions to be less effective and greater potential for representation to services. So I guess potentially we implied in that we need to continue to clarify purposes and expectations of different services, improve navigation for both students and staff and continuity of care, and then also really conduct some research to understand whether changes in services or provision lead to improvements in demand and outcomes for students across their mental health and wellbeing and access and engagement, and outcomes for staff, so their capacity, improved workload, etc. So I will pass over to my colleague Josh.
Excellent. Many thanks, Tom. I will introduce Josh very briefly before he starts. I hope he's here.
I am. Thank you, Essi. Yeah.
Wonderful. Dr. Joshua Buckman is an associate professor in the Department of Clinical Educational and Health Psychology here at UCL. He's a clinical psychologist and a researcher in primary care and community mental health. And his research focuses on understanding treatment, prognosis, personalizing care, and the development of psychological interventions for adults with common mental disorders, particularly depression. And I want to, at this point, really highlight how, although both Thomas and Joshua are focusing on student mental health, they have used some different methodologies in their work, and it just highlights the importance of coming at a problem like this from multiple different angles so we can get a really rich picture. So I'm going to hand over to you, Josh. Thanks very much for making it.
Thanks so much, Essi. It's a real pleasure to be here and really glad to be able to speak to you about this. I'm hoping everyone can see my slides. I've lost the picture of everybody else, but I can see this at least, so I hope you're seeing the same. Tom's really nicely outlined already most of the background here, but I'm just going to speak a little bit more about some things that are rather particular to common mental disorders and substance misuse among the student population. And I think, as Tom's mentioned, we know that a lot of students present with mental health problems when they come to university, and about 80% of those that do have had a mental health problem prior to coming, whether that's current at the point that they join university or at some point earlier in life. It's quite hard, though, to identify the proportion of students with alcohol and drug-related problems. Prevalent studies suggest somewhere between sort of 13 and 39%, but I think we're quite reasonably able to suggest that that's an underestimate. One of the reasons that we think that's an underestimate is a lot of students in qualitative research report that they just don't know who to go to seek help for these kinds of conditions, and they don't really want to speak to university staff about them. They're concerned that it might have some impact on their education or their place at university. To make it quite simple, we know that not getting help leads to bad health outcomes. And so some of the things that we've been thinking about is how we can provide help to people in a way that they feel is more comfortable and convenient, so that they are able to seek it and go and speak to the people that they don't think is then going to have a knock-on effect on their education. And trying to provide something a little bit more specialist, as I'm going to say in just a minute. There was a study that one of our wonderful PhD students, Phoebe, did that demonstrated that students get really quite poor outcomes. Yeah, go ahead, Tom.
Sorry, I think I was sharing, and I don't know whether people can see your slides. I just wasn't seeing anything moving on.
It says you were screen sharing on my screen, but okay.
Oh.
Are you seeing this now?
Yes.
Not
we can.
It's moving fast. I wonder whether this is
yeah.
Tom.
Sorry.
I see moving things.
Okay, good. That's encouraging. Yeah, I was just saying, I'm going to speak to you in just a moment a little bit more about Phoebe's study, where we're demonstrating really that students get poorer outcomes than age-matched peers in our routine NHS services. And that's one of the reasons that we wanted to set up the kind of services we offer at UCL now. Before we jump into that, I thought it might be worth having a little think about something that's a little bit particular about students and their mental health problems, and how come it might be useful to have somewhat more specialist services. So aside from the range of problems that we know students can present with, there are a series of other things that are worth paying attention to in terms of the difficulty in transitioning to university, whether that be from within the same city, from other cities or other areas of the country, or indeed crossing international borders. We know that a lot of our students at UCL are international students, and as I'll go on to show in a bit, that's borne out in the people that come to use our mental health services too. We know that there's quite a lot of pressure on academic work, and I think it's fair to say we bake perfectionism into the system at university, and particularly high-performing institutions like our own. And as you go across the academic ladder and keep going up, that perfectionism seems to get higher, not lower. I mentioned that a lot of students come with a history of mental health problems. Something that can be particularly challenging is managing a transition from where they were receiving some care in their previous location to not getting care when they come to university. And that's particularly problematic for people on medication where they haven't been given any advice or support to taper off those medications, so they have a kind of a hard stop point just before they turn up at university, or indeed in the few weeks after they've turned up. A lot of students are reporting problems with financial strain, and that's the case whether or not they're in paid employment alongside their university education. It can be quite challenging to speak to and identify other people that have been involved in somebody's care prior to them turning up, particularly if that care was in child and adolescent services. And we know an awful lot of students are querying or getting diagnoses for ADHD and autism, or requiring or requesting diagnosis, but the waits for those kinds of assessments on the NHS are so long that most of the time they will have left university before they get seen for an assessment. And I think, as Tom demonstrated earlier, the risk of severe and enduring mental health problems and of suicidal behaviours are pretty high in this age group, and something that we need to be constantly vigilant to. So the first thing that we did as a group was to look at the outcomes for university students in our NHS talking therapy services local to us at UCL. So we have a network of 14 TTAD services that collaborate, share a whole load of data together, and it's a really nice way for us to learn a little bit more about our service populations. And in this study, we were comparing students aged between 17 and 25 with a group of age-matched peers who were in employment. And what we found was, after adjusting for a whole series of clinical and demographic factors that we collect routinely in these services, students were less likely to get a good outcome. They were less likely to reliably recover or reliably improve, but they were no more likely to experience a deterioration or to drop out, which was somewhat surprising, to be honest with you. What we wanted to do was to think about how we might provide services that bridge between the university and the NHS, things that might be a little bit more convenient and more accessible, and see whether or not that would help us improve outcomes. And this is where we've now got to with the UCL University Clinic. You can see that there's rather a lot going on this quite busy slide. Apologies for that. And clearly it's out of date because it says Camden and Islington NHS Foundation Trust, which is now part of North London Foundation Trust. But regardless, there are a series of services we offer. I'm going to speak to you particularly about these three just now. So that's services for adults with common mental disorders like depression and anxiety disorders, and here in the AIM Clinic, body dysmorphic disorder, and then those with addictive behaviours. Referrals to our services most often come from the NHS Talking Therapies teams, but some self-referrals, particularly for the drug and alcohol and other addictive behaviours clinic. We often get referrals through crisis or hospital staff, through the UCL Student Support and Wellbeing team. And I personally get quite a lot of emails from personal tutors or program leads who've got queries about their students, whether they're concerned about them or just want a bit of liaison, and that often leads to referrals into our services. Most of the referrals come in November, so around the time that students are facing their first assignments or getting marks back that maybe they're slightly disappointed with, and in March when again they're about to sit exams or started dissertations. And we get more postgraduates than undergraduates, which fits with the picture at UCL where something like 35,000 or so of our 53,000 students are on postgraduate courses. And we're getting quite a lot from psychology and medical programs, more so than other faculties or schools at UCL. And about 30% are international students. One of the bases of the treatments that we offer is the stepped care model in the NHS, and pretty much all of what we do, and there are some caveats that I won't go into in too much detail just now, but for today's purposes, what we're offering really is considered to be step 3 care, where we might offer high intensity psychological therapies. Just to briefly say what these are things for people that have either had low intensity therapy and they haven't experienced much benefit from it, or with slightly more severe presentations, or for where they have a diagnosis where there's no evidence base or NICE guideline recommended treatment at low intensity. They're delivered by people with specific training in high intensity CBT, predominantly counseling psychologists, clinical psychologists, or trainees in any of these professions. And here in this table, I'm just showing what treatments are available and recommended in NICE guidelines. And you can see that CBT is recommended for depression, for all anxiety conditions, PTSD, and if you separate out OCD from anxiety, you'd see another column with a yes in that for CBT as well. So that's what we do the most of. And then we do a tiny bit of EMDR, particularly for people with PTSD. So I said a minute ago, I wanted to look at treatment outcomes. I compared the outcomes for people that had come through to the university clinic with a matched group of students in the regular NHS talking therapy services in Camden and Islington. Those are the most local to us. This was only based on the first 50 or so cases, so it really needs redoing. But what we saw was among those 50 people, far fewer experienced a deterioration in their symptoms, and a far higher number ended up at the end of treatment experiencing what's called a reliable recovery or a reliable improvement. Now, just to set that in context, across all TTAD services nationally, so it's about 670 or so thousand people discharged from care every year, the reliable recovery rate's around 48%. As we demonstrated with Phoebe's study, it's slightly lower for students. In our services, we were getting a rate around 91%. And far fewer people were dropping out. I think it's worth saying, though, that this needs to be taken with a rather large grain of salt because this was based on quite small numbers, and we don't know whether this is going to bear out continuously as we see a higher volume of patients. Moving on to the addiction-related services. We started setting those up after a mapping exercise to find out what was available, where care was being given, and how students were using the services locally. And that included things done at UCL, things in the NHS and the borough-based drug and alcohol service teams, and third sector support available. Quite a bit of work was done with students and service users to try and understand the needs and referral pathways available and how they were being used, where the problems were, and things of that nature. And we conducted a scoping exercise with a random sample of patients from our talking therapy services, as again, that's where a lot of students were entering the NHS system for care for their mental health. We found some pretty good news. We took a random sample of 800 students that had gone to these services, and I got 4 trainee clinical psychologists to dive into the clinical notes for all of these 800 people and pull out anything at all related to drugs, alcohol, or other addictive related behaviors. And we were comparing what we found this time with a whole service audit we did in 2018, where we got everybody to complete the audit questionnaire pre-treatment to look at alcohol use. And we saw that our students, this time, 61% of them reported using alcohol. It was 55% in 2018. And of those that were using alcohol or reported doing so, 68% said they were using alcohol weekly or more often than that. 12% said that they were using narcotic drugs, and half of whom said they were doing so at least once a week. It's, again, hard to know how much of an underestimate that is. It seems like it's pretty low, but there was nothing else to judge that against. But what we then did was to get the treating clinicians to go through looking at these notes and say whether or not they considered their patient to be experiencing problems with their use of substances, whether it be alcohol or drugs. And that was only reported for 5% of cases. Quite strikingly, only one person in the 800 had any information on other addictive behaviors, things that weren't drugs or alcohol. So very few people, indeed almost none, had anything about gambling addictions or about gaming or pornography use or other addictive behaviors that seem to be important, particularly in the student population. We found that clinical outcomes were pretty good, almost equivalent between those that reported using drugs or alcohol compared to those that did not. But those that did report using were more likely to attend high-intensity treatment sessions, and they were more likely to cancel appointments that had been made for them or to not turn up at all, relative to those that were not reporting any use. So we set up the CUBE clinic, that stands for the Changing Unwanted Behavior Clinic. It's the name chosen by students at UCL, to provide sort of specialist care within the UCL site, but operated on behalf of CNWL as a kind of satellite clinic for the club drug clinic that they run. And the point was to provide assessment and treatment for students with problems related to any addictive behavior aside from heroin or crack cocaine, because the scoping exercise we did had taught us that those were already well dealt with in the borough-based teams who were better set up to provide support for such addictions. And it was particularly striking the number of students reporting gaming, gambling, or pornography use that they considered to be problematic and wanted help for. So we decided to make the clinic available for any and all addictive behaviors, rather than just specifying drugs or alcohol. And it's staffed by a consultant psychiatrist from CNWL and psychologists from that team and some trainee clinical psychologists at UCL. And these are the things that they provide care for. There are three overarching principles for the kind of care provided. It is a focus on harm reduction, based on motivational interviewing and using cognitive behavior therapy, particularly when it comes to relapse prevention. We found that alcohol was the most common concern people were coming with, followed by drugs, and then pornography, gaming, and gambling in that order. Quite a high proportion of the students coming had comorbid mental health problems or met diagnostic criteria for a series of common mental disorders and often for autism or ADHD as well. And there were some really quite encouraging outcomes. Big reductions in the audit score and DUDIT score for alcohol and drugs on average. And again, similarly large reductions on scales of compulsive sexual behavior. So that's the first one is the problem pornography compulsive scale and the hypersexual disorder scale. So overall then, I think what we've found from these studies, both within our NHS services and within the services that we're running specifically for students, is that we're able to pick up cases with people that otherwise aren't being identified in our TTAD services in particular. They seem to be better engaged. Certainly in the CUBE clinic, people are coming much more regularly, and in the Talking Therapies clinic, we got a really low rate of dropout. we seem to be getting really quite encouraging treatment outcomes. As I said earlier, we still don't know whether that's going to be borne out when we see higher volumes of patients, but for the time being, at least, it's very encouraging. It's also fair to say, though, that we have very little by way of low intensity or step 2 in that step care model I was looking at earlier, treatments available. And that means that the volume isn't likely to grow a huge amount unless we're able to bring in a great deal more staff. I think there's still more work to do to ensure that everybody knows about the services available and how to access support for common mental disorders or drug and alcohol misuse and other addictive behaviors. But there seems to be a clear potential for benefit for these services specializing in care for students, and a need to bridge those services in between the university and the NHS, working on either side of these particular student specialist clinics I was been mentioning. Wonderful, that's it from me. I'll stop sharing and see if there's any questions.
Many thanks, Josh, and many thanks, Thomas, as well. So I don't know if we are able to get this screen such that Thomas is also shown in large. I don't quite know how to operate that, so I don't know if Patricia or anyone else is able. Oh, there we are. So I don't see currently any questions in the chat, but please put them there if you have them. Are there any hands? I don't see any hands. While I'm waiting, I'm going to ask a sort of few questions myself, if I'm allowed, chair's privilege. So I would like both of you to comment a little bit on what you think should be the university's role in mental health care. And I know that there are sort of statutory obligations, but as far as I understand, it's not necessarily always clear-cut how those ought to be interpreted. And I know that there is sort of resistance to take on the role of NHS, and I think UCL has quite neatly resolved this by linking with NHS and providing the clinic. I very recently talked with some colleagues from Oxford, for instance, and they said, yes, makes sense that university should not become NHS, but at the same time, if you're in a town the size of NHS, of Oxford, where students would basically clock up all the NHS services, if they went there, then it becomes this tension between the local community and the university. So there are lots of things, but if we forget about those, what do you think should be the role, and how do you think that should be navigated, given what the kind of the primary function of the universities and given the context of the statutory obligations?
I think that's a really important question, Essi. Thank you. I don't know if it would help for me to show the slide again with the UCL University Clinic, but I can speak to it regardless. I guess
I think that would probably be a helpful aid.
Okay, I'm sure I can manage that. What I was going to say really is that I think there is a degree of tension and challenge there in terms of what we offer. The way that we've chosen to try and resolve it is to provide care on behalf of the NHS on the university site. So when a student steps through the door into one of the clinic rooms, that is them in the NHS, not them in the university. But part of the key function of the university clinic is to provide core business of the university, which means that we train university students at UCL to be clinicians on all of the clinical courses. So we've got something like now 21 trainee clinical psychologists and like 5 or 6 PhD students and a series of master's students doing research work with us. So that I think is absolutely central to the model. And then the other is to provide an opportunity for UCL-based researchers to conduct clinically oriented research within the clinic. So that's the kind of way that we've tried to navigate core business of the university versus core business of the NHS in the same space. But it isn't quite so simple, and there are certainly voices that would suggest it should be rather different from how we've done it.
Yeah. Tom, do you have any thoughts to add to that?
Yeah, I mean, I think two things, I guess. I mean, universities historically, I guess, have always contributed to the general well-being of their population, so helping them engage with their studies, progress, develop, and have historically, sort of through their student unions, offered, and their existing services offered, a range of things that are important for development, careers advice, student support services, student union activities to engage sort of in a range of different activities, exercise being one. And then I think, given their reach, I guess, among young adults, there's also a potential for prevention and earlier intervention, and sort of helping them navigate the range of different forms of support that are available. And in terms of their support for individuals who have an existing mental health problem, disability, potentially, there's also sort of a role in sort of supporting those students get the most, not ensuring that they're not disadvantaged during their studies, basically. So those 3 points, I think.
I think that's absolutely right, Tom, and I agree that there's a lot of space for preventive work, and I think where our provost at UCL, I don't wish to put words in his mouth, but I think where the kind of line has been drawn is that where someone's mental health is affecting their ability to study with us at UCL, then it might be the responsibility of the university to intervene and provide support. Where it's outside of that, it might be outside of the scope of the university's work, but that doesn't mean that they can't be supported to access care appropriately in the NHS or elsewhere. It is also worth saying, I think, that we do provide some preventive work. So this clinic here, I don't know if you're seeing my mouse circling, the one that says students affected by war, conflict and natural disasters, that's a collaboration between us and student support and wellbeing, where that is specifically a preventive wellbeing orientated intervention. It's not an NHS treatment, but it's provided by predominantly psychological wellbeing practitioners who have been trained at UCL and work in the NHS, but this is a sort of extracurricular to their normal NHS job.
Yeah, and it's nice that you highlight the importance of preventative work, because I think, again, when you say about students being here and studying, and it's sort of being our responsibility, and I think that's true up to a point, but I think at the same time there may come a point where someone is simply too unwell to engage in the university, and I'm not sure whether it's realistic to expect that the university could fulfill the function of a tertiary care facility and keep someone in at all costs. So, but I think that those sorts of grey areas as to where someone shifts to another kind of jurisdiction, if you like, I think are the really, really tricky ones. I'm going to provide answer for the first question in the chat, which is how student mental health services are funded. Is it by UCL? Part of them, well, the wellbeing services are funded by UCL. I think the university clinic is funded by NHS, if I'm correct, with possibly some funding coming from elsewhere. Josh, do you want to add to that?
It's a complicated picture, I think it's fair to say. Much of it is provided by the NHS. Certainly Camden and Islington, or now North London Foundation Trust, provide some compensatory pay for the time of clinicians, myself and others included. The student support and wellbeing service for students affected by war, conflict and natural disasters, that's paid for by UCL. The Psych Up for Wellbeing team had some seed funding to pay for some of the peer support program, and Tom has been running that separately. And now the new clinics for ADHD and for autism that are being set up currently, that's a little bit of a mixed model across a couple of NHS trusts, again, who have now merged. So it's pretty much the same trust, but yeah, I think it's slightly more convoluted and complicated than otherwise it might be, but predominantly NHS for the NHS work.
Reflects the sort of the confusion of what it ought to be and make it.
That's fair.
Yeah. There's a question from Georgina, who's one of your university clinic colleagues, who's asking whether you have a sense of why outcomes for students might be better in the university clinic compared to iCope. Is it because engagement is easier because they're embedded within UCL? But
I think there's probably 3 or 4 reasons behind it.
And I guess Georgina is also wondering whether there is practice then there that could transfer to other NHS services to improve outcomes for them.
I think that, like I said, there's probably 3 or 4 reasons for it, and these are not necessarily specific to our clinic, but we know from our research group that have done a lot of work on NHS talking therapy services and analysed the national data. We know that if you get people care more quickly, they tend to get better outcomes. We know that if you provide them more therapy sessions, they tend to get better outcomes. And if you do that over a shorter period of time, they tend to get better outcomes. And we probably do all 3 of those things at the UCL University Clinic. Some of that's circumstantial and just due to us being available a bit more and not having quite such a high volume. I think there are some differences, though, in that a lot of the students we take are people that have been waiting within the main service for quite a while, and they just come to us when they're at the top of the waiting list. So there isn't really any difference in the speed for those folks, but people that have self-referred in or been somebody's contacted me or one of the other team to say, I'm really concerned about this student. Could you see them? Can you fit them in? We tend to be able to get to see those people more quickly because there's just less of a wait through the various layers of bureaucracy in terms of registering and other things within the services. So I think that's probably part of it. On average, we see patients for a bit longer, probably 2 sessions more than they would be getting in the main service. That's partially down to me and my decision making as a supervisor or a clinical director. I think it's more important to provide good quality of care and keep going if someone's getting better rather than stop because of the time pressures to see somebody else. But obviously that does mean that there are difficulties in terms of the number of people you see or other priorities. So yeah, it's not always the very best option, but it's one that I believe is likely to lead to better outcomes.
Great, that's a very comprehensive answer. So there's another big question that sometimes sort of, I'm not sure it keeps me awake at night, but it certainly niggles at the back of my mind every now and again, which I'm going to ask because there are no new things have come up at the chat so far. So it seems to me that some of the way in which we have traditionally done university wellbeing or mental health services have been sometimes a bit of a knee-jerk reaction to very high-risk events like suicide and self-harm. And we know that it's on a level of an individual, it can be incredibly hard to predict who will go on to commit suicide and who doesn't. And we have some good idea of risk indicators, but they're not sort of hugely reliably predictive. And I wonder what your sort of thoughts are, and this maybe circles back to what Tom has just been saying about a more holistic and prevention-focused service as well, is about if we think about where you'd want to be in 10 years' time if you would do this well and in an evidence-based way, how would you like to see it progressing in a systematic way?
Are you talking specifically about suicide prevention?
No, I'm thinking mental health more broadly, but that embedded in it.
I think, as you said, Tom was absolutely right, that a holistic approach is entirely essential. I think getting people together and sharing best practice and sharing responsibility is really important. I guess if you go to or look at any of the coroner court notes or people that have died by suicide in terms of what happens, there's often gaps and people falling in them and lack of communication that has led to a series of circumstances where something's been missed and opportunities to provide care have been missed. And so I think that holistic approach is going to be essential there. And certainly when with Alexandra and with people in student support and wellbeing and elsewhere, we were rewriting the student and staff actually suicide prevention strategy for UCL a year or 2 ago. It was remarkable how holistic it was and who was involved and the really deep thought that was given to ensuring that a whole series of stakeholders were involved, including security staff and accommodation teams and you name it, a whole series. So that I think that was really important and will continue to be so. I think that's also the case in terms of mental health, that we're providing people that have contact with students in any capacity, whether that's in pastoral care or otherwise, with the skills and knowledge of who they can go to get that student help should they need it, or how they can have conversations that might be supportive and mitigate the need for help. I think that is going to be an essential part of it. And we do have quite a lot of liaison with our colleagues who are providing personal tutoring or other things. But, you know, SSW have done an awful lot of work in that space and certainly more expert in it than myself and others in the clinic. Yeah, I don't know, Tom, do you want to add anything?
Yeah, I mean, I would echo what you're saying, Josh. I guess sort of thinking sort of 10 years ahead, I guess maybe perhaps a clearer and more defined role for each of the different institutions and perhaps a more symbiotic relationship between the two. Perhaps the greater use of quality data and evaluation to inform decision making in both, and also I think sort of hopefully a system that is more able to elicit need and get people to the right places on the first attempt, or at least potentially. So those sort of four
I
things.
think I see Argyris is on the call as well, and this is something that in the Grand Challenges we're very keen to support, but also very keen that all of this would progress in an evidence-based fashion. Argyris, is there anything you would want to add or ask?
No, I think just to echo that what has been said, I think this is very important, and it is important to realize that without the necessary data, we can't audit, we can't improve the quality, and that at the end of the day is something that damages all of us, including the people whom we're there to help, who are the students. So focusing our efforts on having transparency, data and accountability, as both Josh and Tom, who are really experts in this, said, is I think very important. And it's not that difficult to achieve nowadays. Like it is very feasible, I think, from a technical point of view.
Yeah, excellent. I don't see any new questions in the chat. I'm going to just do one final kind of gone. If there aren't hands going up or anything going to the chat, I think we will wrap up a little bit early. I want to highlight to people the upcoming Catalyst seminars, for which Patricia has put details on the chat and how to register for them. And we are also reminding you of special in-person event on 4th of February, which is during the Children's Mental Health Week, where adolescents will be interviewing mental health researchers on topics that most matter to them. So we hope to see you in the in-person event, and we also hope to see you in the future seminars. And since I don't see hands or questions, I want to thank our two excellent speakers for their really informative and interesting talks. And I want to wish everyone happy holidays and see you in 2025.
Thanks so much, Essi. Real pleasure.
Thank you, Essi.
Thank you.